I was thrilled when our patient advisory groups got together to plan their part of the program, and along with Mort Cowan, they decided that what they really needed most was to hear from an expert about what coronavirus pandemic means to people with primary immune deficiency. And who better to help us look at this question than Steve Holland. And everybody knows Steve. He's recently become the director of the Division of Intramural Research at NIAID. So Steve, you don't need any further introduction. Please share with us what you think.
Thank you very much, Jennifer, and to the group here at PIDTC. I'm enormously grateful to have a chance to talk with you. And I'm going to go through in the next few minutes a variety of things. You know, trying to give a general introduction to COVID-19, I think, is probably not necessary in today's world. Lots of people are working on this, and we are saturated in our information about it. Many of us, though, have had to step back from workplaces that we love and that we have been engaged in, and looking around for how to put that in perspective, really trying to find the people that have stepped back so effectively and figuring out from them how to go forward. But I need to talk a little bit about the actual virus. And, you know, like you, I spent all my time waiting to learn how to pronounce SARS-CoV-2 or come up with some nifty acronym for it. But frankly, like you, you know, I was not paying attention to these coronaviruses. I thought that they were annoyances, but not certainly major causes of disease. But now I have the time both to wear flannel and to learn a little bit more about them. And I'd like to share some of that with you. So, you know, this is yesterday's map. I was not thinking that in 2020, the way that the United States would turn blue was this particular way. But it is a real concern that we are still increasing our numbers of cases, and it makes it very difficult to understand exactly how we're going to safely and wisely step back from the kinds of restrictions that we have. So there are a few questions that come up as we talk about these. The first one, I think for many of us, is where in the world did this come from? How many of us knew what pangolins were in the first place? But whether it is from bats or from pangolins, the critical point is that this is not an agent of bioterror, and it was not an intentional release made by people who were trying to come up with evil designs. This is a leap of an animal virus from animals to humans, and trying to understand exactly where that is and exactly how it has happened is something that will occupy many people for quite a while now. But it is definitely not a man-made problem. Now, how do we understand animals that get it? Working with bats or pangolins is very difficult, but we're going to have to come up with models that allow us to really develop treatments and develop strategies. And in a really striking paper from Science recently, this group identified that cats are susceptible, and as you've heard about lions, tigers, not so far bears, but cats certainly are susceptible, and they can get it by natural forms of transmission, that is, by transmission in environments from one animal to the other. Ferrets are also relatively susceptible, which goes along with some of the work that's already been done in influenza. And because there is a fair amount of work working on ferrets, that may turn out to be helpful. You'll be relieved to know that dogs and ducks are both really quite resistant. But animal modeling, as you really try to get that done, is a big deal. And trying to get animals that are small enough and tractable enough is a major effort. Mice are not susceptible to this particular virus. They need the human receptor, and that human receptor ACE2 can be introduced, but those mice are in extremely short supply. And it's not yet clear that they will get a disease that looks like what we get, which is really what we want to study. As we move into other animals, issues of supply and how useful they are for countermeasures become difficult. In our own institute, one of the big emphasis has been on Indian origin rhesus monkeys that have been used for SARS-CoV-1 and MERS, and now SARS-CoV-2 or COVID-19. And what you see here are just some plots from the group of Vincent Munster and Heinz Feldman out at RML. The group, these have been using these monkeys for a long time. And you see that when you infect them with COVID-19, they get sick, and over time they get better, and that's good. In addition, and perhaps more importantly, for much of what we want to be able to study, they actually get pneumonias, and you can see here these areas in red are areas of pneumonitis that looks very similar to what we see on human x-rays. And then in the pathologic specimens, you can see that they get a consolidating pneumonia. And on the bottom of those pathologic figures, you also see that they stain positive for the virus so that you can actually identify viral infection in those sites. So the animals are a useful model. And we can identify the virus in their various secretions, and we know that they are responsive to some of the drugs that are being used in the treatment of humans. So I think that this Indian origin rhesus model will at least be useful. Whether it's the best model, I don't know yet, and it's certainly not the only model that will be used. But these other species, especially ferrets, may turn out to be helpful, and we may need to be thinking harder about those in the future. What about antibody testing? Well, as you know, Dr. Pitt has been working very hard on this, and the antibody market now is quite saturated. There are more than 100 companies that have reported that they have assays that are effective for screening out people who are seroreactive to SARS-CoV-2. However, despite many strong assertions, the vetting for these has not yet been strong, and there are no head-on-head comparisons published yet, but they're coming. The more important question than simply what happens in the laboratory, that is, can you recognize antigen, is do these antibody titers that are being recognized, do they neutralize virus? Do they prevent infection in actual humans? And if they do, how long do they last? We know that there are now therapeutic trials of convalescent plasma being administered to patients who are ill. And at least so far, those trials look like nobody's getting worse from them. But until they're randomized and prospective, we won't really know if they're effective in making people better. I just include one paper that is in press now at the Journal of Infectious Disease from Peter Burbello and Jeff Cohen's group here at the NIH, showing that there are differences in rates of evolution of antibodies. And here you see on the left panel, nucleocapsid, and in black are those samples that are at 14 days. In gold are those samples that are taken less than 14 days. And what you see in these people who were infected with SARS-CoV-2, what you see is that the nucleocapsid signal is quite clearly positive by 14 days, whereas not everybody who was PCR positive was spike positive, was antibody positive at 14 days, just suggesting that there are going to be differences in the targets, and this has to be taken into account as we think about the antibody tests. Reassuring to those people who want to work with these plasmas for antibody work and have them be less infectious. Heat inactivation at 56 degrees does not seem to damage the antibody titer, though it does clearly inactivate the virus. There are a lot of vaccines being produced. The one there on the top, the mRNA 1273, was one made between the Barney Graham and Kizzy Corbett at the Vaccine Research Center, along with Moderna. It's an RNA vaccine that went into humans about a month and a half ago in Seattle and has now moved on to its highest dose level. You may have seen reports of the chimp adenovirus vaccine from Oxford that looks very good in the macaque model and then is moving into humans. But there are many other vaccines being touted, and you can see a list of several here, as well as BCG and some other vaccines that are in development. So there are a lot coming. But it's important to keep our expectations realistic. And in this somewhat cautionary tale from Galanti and Shaman that was put out recently in medRxiv, they looked prospectively at people in New York for rates of infection with a variety of seasonal coronaviruses. And what you see here are the different seasonal coronavirus rates over the course of time from their enrollment. Well, that's not so surprising. These are highly transmissible viruses in the community. These are not COVID-2, but they are seasonal coronaviruses. Some of them are beta coronaviruses. More troubling is that in those people who had had infection before, what you see here in this graph is the rate of developing reinfection with the same strain of coronavirus. Now, you do notice that it seems that the rate seems to be relatively low for about 36 weeks, and then it goes up. But this should keep us somewhat humble about our assumptions of what a seropositive status might actually confer. And I just want to point out in a cautionary moment that there are several other major pathogens for which there has been extraordinary effort over decades now trying to develop vaccines, and not for lack of effort or intellect or activity, have all of the pathogens on this screen so far failed to yield to any significant antibody therapy. Now, you know, as we talk about the disease, I think we all now know a lot about what this disease is typically thought to be. There, of course, have been people around the world who have been persuaded that it was just a trivial respiratory disease, but people have made mistakes in assumptions before, and it's important to keep that in mind as we go forward. Just to remind you that this disease has really a much more pleiotropic set of manifestations than we thought. Here is a recent report of large vessel stroke in relatively young people, not all, you know, one gender, not all with underlying pre-existing problems. In addition, neurologic manifestations of SARS-CoV-2 infections seem to be somewhat complex and suggest that we really need to be on the lookout for these both presentations and complications as we go forward. And finding strokes and leptomeningeal enhancement is certainly a concern for us as physicians. And then finally, you know, this also can present as myocardial disease in a group that you might anticipate with myocardial problems as well, older, predominantly men with some underlying conditions like hypertension or hypercholesterolemia, but still presenting often with these problems. So it will be a complex and phenotypically expanding problem. Now, I wasn't asked to come and talk about that. I was asked to talk about this in primary immune deficiencies, and I've been skating around it because, frankly, we don't have a lot of information about what's going on in primary immune deficiencies. Not for lack of looking, but even in high rate areas, the frequency of developing this in the population is still at the very low rates, which might not yet have penetrated far into patients with primary immune deficiencies. So what can we say? Well, the first thing we have to say is, like everything else that we do, it's critical to participate in research. And there are research programs, I've just cited two of them here, set up by the Clinical Immunology Society and the European Society for Immunodeficiencies that can link you to registries that are very keen to get people signed up to try and figure out months down the road from here exactly what is going on with PIDs and this disease. So we're going to have to look for surrogates, and we're going to have to look for the surrogates that people have already collected. here in a recent report of what happens with people with kidney transplants, some of whom are taking the same drugs that our patients are taking. You can see that the risk of disease is high and the risk of death was high. Now, what we don't know is exactly how complex these patients' diseases were before they got infected, but it is a reminder that being on some of these transplant rejection inhibiting drugs does not seem to be fully protective. More perhaps to the point for much of what we do, this paper that just came out yesterday detailing 105 cancer patients in Wuhan and a similar a age, sex, and race matched control group that included 9 patients with hematologic malignancies and 6 patients who had received immunotherapy. Now, these numbers are, of course, big in some ways, but very small for what we care about. And I just want to share them with you to point out that, not surprisingly, having cancer is its own risk factor for doing worse. And you can see here in orange, those who had cancer had higher rates of every bad outcome, severe or critical disease, ICU, hospitalization, or death. And you can see that the proportion was much higher than in those who did not have those predisposing factors. In addition, in their group, those that had hematologic cancers fared worst of all, followed by those who had lung cancer. And this is important because for us, many of our diseases have pulmonary manifestations. Those are a major part of most immune deficiencies. And not surprisingly, those who had metastatic disease fared worse than those who had non-metastatic disease. Now, I think important again for what we do, it is shown on this slide that those who had lung cancer had similar rates of severe disease to those who had other cancers with lung metastases. That is, lung involvement seemed to be a significant risk factor for doing badly. And I think this has got to be important as we think about our population, many of whom have recurrent pulmonary insults. And then finally, as we think through what are the different therapies that should be explored for what will make people able to resist this virus, immunotherapy has been a major game changer for cancer. And it is concerning to see that those patients who got immunotherapy in this small trial in China, those who got immunotherapy had worse outcomes than those who did not, suggesting that, and these were all PD-1 blockade patients, suggesting that PD-1 blockade may, not surprisingly, actually exacerbate some of the inflammatory problems around COVID-19. So just to summarize this paper, sicker cancer patients have higher rates of severe outcome. Lung involvement in and of itself is probably bad. Localized extrapulmonary disease and radiotherapy seem less important, and immunotherapy seems to be a major risk factor. So let me just move to prevention and just remind you that there are lots of things that people talk about for prevention. This is not one of them. So in terms of what's really important, we think, and I think with good reason, that this is spread overwhelmingly through droplet spread in the air. And in this small report published just recently in the New England Journal from a group here at the NIH that used light sheet technology to visualize droplets in air from speaking. What you see here on the left of the screen in those green spikes, those are droplets that are released when somebody speaks into a small box and says, "Stay healthy." And that is on the right, you see the droplets that are actually liberated. And this is really the reasoning behind wearing masks. These preventive, altruistic masks are so important. And this paper really helps to drive that home. This is now looking at one of the nursing home outbreaks in Seattle. And what you see here is that many people who were pre-symptomatic at the bottom of the screen or asymptomatic were still PCR positive, and many were culture positive, meaning that we cannot trust that just because I feel fine does not mean that I am fine. And it does mean that wearing a mask is an essential part of our altruistic obligation to our colleagues. So right now, preventing spread is our best bet and our best advice. And we really need to be entirely symptom agnostic, even when touring the Mayo Clinic. So let me just come to the very end and mention treatment. I think hydroxychloroquine is a done deal, and there are plenty of reports of not just failure to improve, but in fact, worsening. Steroids are an untested component of many treatment regimens. I have nothing bad to say about them, except that they are not often factored into some of the prospective trials of immunomodulators, despite the fact that they're being used quite frequently. Tocilizumab is now being looked at prospectively. Remdesivir has been looked at prospectively, both in China and now here, and the recruitment trials are complete, and I think we ought to have final information out shortly. Baricitinib is being trialed with and without remdesivir to see whether that form of immunomodulation is important. And acalabrutinib has been recently stood up as a trial to see whether that is important. There are reports of BTK deficient patients having milder courses of disease, and there are reports of BTK inhibitor receiving patients having milder courses of disease, which were some of the factors that got people interested in these. Finally, just recently, an NIH treatment guideline summary statement was published, and I've listed its URL here, by many of the same people that were involved in putting together some of the HIV treatment guidelines. So they really are very good at putting together consensus and hard data. So I'm going to come to an end here and just say, you know, there's been an outburst of medicine and science over just the last few months, with remarkable advances in epidemiology, mechanistic insight, serology development, as well as vaccine development. I have no doubt that all of these will turn out to be important, but I think we have to be a little bit agnostic about when they'll turn out to be important and how important they will turn out to be. This disease has pleiotropic manifestations, and in this sense, we have a molecular diagnostic in the PCR, just like we do for our primary immune deficiencies. And as we apply that molecular diagnostic, we find out that we're not as good at our clinical phenotyping as we thought we were. And that phenotypic expansion really is a reminder to be humble. And when we are trying to be humble, we should also try to be careful to collect hard data and not just what we expect. There is most likely an increased risk to most primary immune deficiency patients, although those who have defects in BTK may not necessarily be among them. And the good news, since I don't know when we're going to have a vaccine and I don't know what serologies will predict, the good news is that treatment trials are really underway, and I think we are likely to get some observations. So stepping back has been important, and I think all of us have stepped back in order to prevent transmission within our workplace and to be ready to step up. And here, you know, Tony Fauci and Deb Birx are getting ready to show us how to do it right. And I am absolutely confident that with all of our support and input, we will kick this, and we will kick it good. Thank you very much. All right, be happy to take any questions here if I haven't exhausted all my time.
Well, I think everybody should unmute and applaud, but thank you, that was wonderful. And of course, I want to ask you the crystal ball question that Tony Fauci gets all the time. How do you see this evolving over the summer into the fall? Are we going to have more waves, and how long is this going to take?
I don't know. I think that, you know, we've, having survived through several other pandemics, or epidemics, everything from SARS to MERS to different flu strains. I think it's important to be ready for the worst, but not to necessarily, we need to plan for it, but I don't think we can anticipate it. I don't know what the fall is going to look like. It could look quite bad. Certainly that's what we ought to be ready for, but I am not confident that I know what that is going to bring. So I think that's why testing is going to be so important. And obviously as the testing changes, it may go from PCR to antigen, or there may be other tests coming. And as those tests evolve, our ability to roll out universal screening, which is what we use for many, many other diseases, I think should come in line. And I'm very confident that once we get to universal screening or closer to universal screening, we'll be able to handle this much more effectively. Right now, we're still hobbled by phenotypic expectations that simply don't meet reality.
I think anybody with a question or comment, feel free to unmute and just get it.
I have a question, Dr. Holland. This is Felicia from the CGD Association of America. Thank you for your talk. I really appreciate it.
Thank you.
Given that the CGD community does have a very strong inflammatory response to infection, how does that correlate with COVID-19? We know that we have the ability to fight viruses similar to the general population. But my questions are two questions. So the inflammatory response, how does that correlate to COVID-19? That's number one. And number two, I understand the CGD population can be more at risk for secondary infection. And so if you could speak to those two questions, I would appreciate it. Thank you.
Sure. So let me just say that there's no question that patients with chronic granulomatous disease have a heightened inflammatory response. Now that could cut in two different directions. If it's heightened early, that might actually be helpful in terms of preventing establishment of the virus. And as you point out, CGD patients handle viruses for the most part quite well. However, if the virus gets established, there might be inflammatory problems down the road. You know, I think of it a little bit like braking on a car. If you brake just a little bit, but you're a good distance away from a target, you'll be fine. If you wait until you're right on top of it, you won't. So I'm not sure. It's surprising to me and reassuring that so far we have not been notified of any of our patients with chronic granulomatous disease who have had COVID-19 infection. That doesn't mean that'll be the case everywhere. But I'm not sure what it will do to them. I think this is a strong argument, though, just like we say, you know, you ought to get as many vaccines as you can to prevent other infections that might be confusing. Staying on prophylaxis for CGD patients would be critically important to make sure that they don't get in trouble with these super infections should they get sick with this particular virus.
And when you say prophylaxis, would that include Actimune as well? Because there have been some studies regarding interferon and COVID-19 specifically, which have been a little confusing.
Yeah, I think that's a very important question. I'm not sure what interferon gamma would do to people who got infected with COVID-19. Again, you know, I think I would urge people not to add it if somebody was sick. I don't know whether it would make a benefit as a prophylactic. This is our approach to interferon gamma in general. We don't add it when people are sick, but we think that it works as a prophylactic. So my advice in general has been not to have people change their therapies based on anxiety about the virus in the community, not to change non-steroidals or their blood pressure management or their interferon. If you're on it, stay on it. If you're not on it, don't stay on it. But I think that it's very dangerous. We don't know enough about how these things interact for me to think that it's wise to be changing what we do.
Thank you.
Thanks. So there are a couple of
I could
questions in the chat.
I could just comment that I'm aware of one patient with CGD who had COVID, who had lung disease and did just fine. That's one case, but it's at least a little bit reassuring.
Thank you, Dr. Malik. That is reassuring. I really appreciate it. We'll take all the reassurance we can get.
Okay, someone's asking, are other coronavirus antibodies present in IVIG, and might these give some cross-reaction and assistance to PID patients?
I don't know the answer to that. I think that's an important question that people have been wondering about, and I've not seen the data. But I'm sure that as we go along, there will be those antibodies in IVIG. Whether they'll be helpful, I don't know.
I could just comment again that I've been interacting closely with CSL Behring and others who are planning for sure to develop hyperimmune IgG products that initially they'll be testing, but eventually they're committed to making sure that if it's useful, it'll be available to immune deficient patients who need immunoglobulin of that sort, a hyperimmune globulin.
This is Gigi. Steve, I may also comment.
Yeah.
As you know, collecting samples from Brescia, Italy, and in that cohort of COVID-19 patients, there was one of the 2 XLA patients that have been reported in the literature with COVID-19. We tested antibodies with Jeff Cohen. We suspected that patient shouldn't have any anti-COVID-19 antibodies. He did. So the only reason for him having antibodies with COVID-19 is that there is some cross-reactivity between IVIG and COVID-19 antigens. So there must be some IgG reacting to COVID-19 antigens.
Well, thank you, Gigi.
Okay.
I just had one question.
Sure.
Dennis Hickstein. The Washington Post has a front page story said the results are positive in the NIH study for remdesivir.
Well, that didn't go through me, Dennis. I don't know what to say. I mean, I think, you know, I would wait until it is at least in an online version so we could see it. The results from China have been, they're, I think, encouraging, but not definitive. I would like to see the paper. I've not had a chance to look at the data.
Yeah, they said NIAID's going to announce it today.
I look forward to it.
Well, and I think that is sort of a note that we can end on. Obviously, we have little information now. We're going to get a lot more. It's going to have to be carefully evaluated, and there's a whole lot coming out that is not as well reviewed as we're used to having. And so I think people have to be very careful in assessing information that comes out. So I don't know, any last thoughts, Stephen?
I see Manish is not happy with the science about cat infection. I would just say that no, it's not a great paper. On the other hand, any cat getting infected by being in a cage to another cat, that strikes me as a transmission event. And I think transmission events are probably worth noting. Yeah. Whether it needed to be noted in science, well, that's another issue.
Yeah, sorry, I just took exception to that particular part of the study. But I can comment also about the immunoglobulin question that was raised earlier. We have actually gotten about 100 lots of immunoglobulin from 3 different manufacturers and have tested 6 different antigens for antibody binding. And there are some lots that do have binding, so that echoes what Gigi mentioned a few minutes ago. And we're writing that up right now. We have not been able to demonstrate neutralization, just FYI, but definitely there are some lots that have binding.
Okay, well, this has been extremely provocative and helpful. Thank you, Steve. And I think now we get to turn to perhaps a little less speculation and more science with our best abstracts as directed by Sun-Yun Pai and her selection team. So Sun-Yun, do you want to take over for this section?
Yes,
Thank
although
you.
I think what we've devised is that each person will share their screen to present their abstract. So first, I do want to thank the abstract committee for the assistance in reviewing the excellent abstracts that we received. These 4 are the ones that we chose for oral presentation. It's a shame, that we're not able to engage in a poster session in person for